I have my privilege to introduce our part and member of local organizer Gouvas N with his topic about the impact of lab to open PME conversion to the oncological outcomes. Nick.
Thank you very much for your kind words. I'm pretty sure that most of you are not concerned about this subject because obviously you don't convert. But probably there are some people in the room that they still convert. But let's see if that's the case. First of all, if we want to look at the outcomes of the converted cases, we need to have a proper definition. And I think we're still struggling of getting a proper one. And this is how the definition of conversion progressed. I mean, any implant incision, so when I'm doing a laparoscopic operation, if I just put another trocar just to help me retract a bit better, is it a conversion? Because it's an unplanned incision, the trocar wasn't supposed to be there. After that, length of incisions, different length of incisions. So if I, for example, define my conversions as an incision of 6 centimeters, if I do one that it's 5 centimeters, is it not a conversion? So we have trouble with the definition, and we want a proper definition because we don't want to compare apples with oranges. Anyway, however you define conversion, it refers to the point at which somebody realizes when he's doing or she's doing a laparoscopic procedure that continuation of the operation is no longer appropriate, because you're either going to do some damage, and that is about the safety of the short-term safety of the patient, or you either will compromise probably the oncological outcome of your patient. Conversion cannot be considered a complication of laparoscopy. It's a limit to the feasibility of the technique. We know the results for laparoscopy for colon cancer, faster recovery, less morbidity, similar oncological outcomes with open, but what happens with rectal cancer? These are the conversion rates for colon cancer. These are studies from the 90s, and you see that the conversion rate was quite variable, from 5 to 25%, and the same was for the RCTs. What about rectal cancer? So laparoscopy for rectal cancer, when it started, it slowly picked up. Now it's very, very widespread. Okay, there are still technical difficulties, especially when you're dissecting down in the pelvis. And now, I mean, even recently, again, there are some discussions about oncological compromise of laparoscopy. Otherwise, short-term results are very, very good. Less use of analgesic, less morbidity, shorter hospital stay, our patients do better, and they do better faster. Where are we at the moment? This is a very recent study done by the Dutch Surgical Colorectal Audit. They wanted to see their progress as far as conversion is concerned. What they could find is for both colon and rectal cancers, they were doing more operations laparoscopically, they're completing more operations laparoscopically, but the portion of the cases that they had to convert remained the same. So here are the converted cases about colon and rectal cancer, and it is around 10%. So now, this is a very special subgroup of patients, obviously, because there are some limitations during the operation that they will make the surgeon to convert. So this subgroup of patients, are they having similar results with the other patients, either operated laparoscopically or open, or are they doing worse? We have plenty of evidence saying that they are doing worse, and some that and only actually one study that claims that they are doing similar. But what's the comparison? Do we compare this subgroup of patients with laparoscopically completed? Is it a fair comparison to make? Or we have to compare them with the ones that we are starting open straight away? So this is the results of the converted cases from the COLOR 2 study. They had the conversion rate of around 17%, as you see here, and that didn't change over the years that the study took to complete. These are the reasons of conversions, and then they only compared the converted cases to laparoscopy or open surgery, but it was only for short-term results. And actually their findings, they're quite expected, to be honest, because they found that compared to laparoscopic surgery, the cases did far worse. Compared to open surgery, they were quite similar, but the total number of complications when compared to both laparoscopic and open surgery, the converted cases were doing worse. When the morbidity was further analyzed, they couldn't find any statistical difference. This study comes from Morocco and Algeria. It is from 2 units. It's from 2005 and 2013. And there is a conversion rate of 26.7%, which looks quite high. But this is the real world. So what they could find is obviously that the predictive factors for conversion was if your tumor was really deep in the pelvis, obviously you have a higher chance of converting. And obviously if your tumor again is quite bulky and quite advanced, again your chance of converting is higher. What they found when they did the multivariable analysis, they found that conversion was an independent prognostic factor about morbidity. And what they could demonstrate in their series is that when you convert, your patients have higher chance of global morbidity, more anastomotic leaks, and this is very, very interesting, and more reoperations because of this morbidity. Then there were concerns also about the long-term oncological outcomes of the patients, because there were some studies, and this is a meta-analysis that includes both colon and rectal cancer, and there are some studies here that they show that the converted cases do worse oncologically as far as overall survival is concerned. This is another quite recent study done in Torino from 1996 to 2011. It is a retrospective analysis of all the rectal cancer cases, and the data was collected prospectively. These are their intraoperative results. Actually, what they did is they compared the 3 groups, and then they compared only the conversions to the open cases. So they couldn't find any real differences between the converted and the open cases as far as the intraoperative results were concerned. Sorry, and the same for the postoperative results and the complications. No difference between converted and open cases. Again, the same for the pathology results. The CRM positivity was the same. The pathology stage was the same. Number of lymph nodes were the same. What they could find is that, the overall survival was not, there was no difference in the overall survival between the converted and the open cases, but they could demonstrate not a statistically significant difference, but a tendency that the converted cases probably would do worse as far as disease-free survival is concerned. But again, I'm saying it was a tendency and not statistically significant. So there are a lot of studies out there trying to look at the outcomes of the converted cases, but obviously they are very, very heterogeneous. So we had the pleasure of working together with the Prof. Tekis group, and we tried to gather this and study them in a more systematic way. So we ended up with 13 studies, only for rectal cancer again, I'm saying. And what we could find is, this is quite easily expected. Obviously, the converted cases bear a higher BMI than the open ones. As far as age is concerned, there is no difference between the 2 groups. Again, neoadjuvant treatment, there's no difference because neoadjuvant treatment doesn't depend on conversion, it's a pre-operative thing. But what we could find, and again it was expected, is that the conversion group bears higher incidence of more advanced disease, namely stage 3 and stage 4 patients. The operation duration was the same between the laparoscopic and the converted cases, and the hospital stay, obviously, it was in favor of laparoscopy. There was no difference in mortality. and no difference in morbidity. So when we further analyze the morbidity, we could find, again, a tendency favoring laparoscopy. And I'm saying a tendency because if you check the p-value is right at 0.05. And so you cannot conclude that this is statistically significant. There is also statistically significant difference favoring laparoscopy as far as wound infection was concerned, and this was to be expected. The lymph node harvest between the laparoscopic and the converted cases was the same. The local recurrence, we couldn't find a statistically significant difference between the two subgroup of patients. But interestingly enough, we could find that converted cases had a higher rate of distant metastases. And this is very, very difficult to interpret because of the heterogeneity of the studies. As far as overall survival was concerned, at 5 years, there were no differences again. Then we decided that we should compare also the converted cases to the open ones. It's not fair to compare converted cases to laparoscopy. When we did all our comparisons, the only thing that we could find a statistically significant difference to was the operation duration, but that was again to be expected. All the other parameters, they were non-significant. So, conclusions. Obviously, when you compare laparoscopic and converted cases have a higher BMI, an increased duration of surgery, increased morbidity, and especially increased leak rates. And we don't know if this is only, this is a multi-factor thing, because it could be the surgeon's fatigue and technical compromise, because it's different if somebody experienced is operating on a patient, obviously, and somebody not that experienced. And again, it depends when you convert. If you are trying for hours and hours to do the operation laparoscopically, and nowadays, especially in the UK, the laparoscopic rate can sometimes be an outcome measurement where you can where you will be, for example, if you want to be appointed to a job, you should have a very good laparoscopic rate. So everybody is trying to complete the operation laparoscopically. It could be because of extensive manipulation of tissues and damage to the vascular supply, and especially when you are not converting preemptively and you are converting when this happened, then most probably your anastomosis won't be that good. And then we don't know if there is some kind of an altered post-operative physiology because of the conversion that doesn't allow the anastomosis to heal. There is obviously increased hospital stay for the converted cases, but same number of retrieved lymph nodes, increased rates of metastases. It's about the more advanced stages, but if it's for the more advanced stages, why don't you see the same for the local recurrence, for example? And similar local recurrence and overall survival at 60 months. As far as open versus conversions, only the operation duration was longer, no other difference. And we had to stress that there is a quite significant heterogeneity among the studies. So conclusion, I'm afraid about this subject, where somewhere like that, somebody could say it's not a problem. So if it's not a problem, okay, don't worry. I think everybody would admit that there is a problem, but is there anything we can do about it? Do we know what we have to do about it? Do we have any, for example, if we think that there is a real problem there, do we have any factors that can predict that the patient will be converted so we can start straight open? It's very, very difficult. Unfortunately, there is very, very limited data regarding this subject if you are converted preemptively or reactively, meaning preemptively you go in, you are quite experienced, you see adhesions, you see a bulky tumor, you say, okay, we will get in trouble, let's convert. Reactively means you try, you damage something, you cannot continue like that, so you need to convert. Unfortunately, the data is very, very limited and it's only on short-term outcomes. Experience of the surgeon, of course, because the main factor here is the surgeon. we might be able to save ourselves the trouble of converting if we have some technical improvements of the instrumentation that we have currently in hand, and especially when we are translating distally the rectum deep in the pelvis. So this might be the future, because slowly but steadily there is evidence coming up that, obviously from very, very specialized centers, that they are saying when you're doing the procedure robotically, your conversion rate is quite significantly lower than when we're doing it laparoscopically. Thank you very much.
Thank you very much, Nicholas. Any questions? It's one in the back. Hang on, Professor, just 1 second. I'll get your mic. None of us hear it.
I have a provocative remark. Coming from open surgery, going to peritoneal surgeon, which is also have wide incision, and then I saw the patients have recurrence, also after laparoscopic colorectal surgery. And sometimes I do not understand why the trocars have 3 millimeters laterally from the midline incision, or somewhere not in a position. They put the incision like this and not like this. So it is very difficult then to remove all the cancer from these trocar metastases and peritoneal metastases, to have a zero resection in these kind of patients. So sometimes, and this is provocative, I think that laparoscopic colorectal surgeons think that they will have no recurrency and that they can put their trocars somewhere in the abdomen. And if it is not possible, then they make an incision and have lots of holes on the abdominal wall. So is that true? Or is it just provocative? Sometimes I think if I have the 30% of recurrency, I see the disaster on the abdominal wall, and I think, well, why the hell did the trocar 5 millimeters away from the midline incision? Does it really help? Is it necessary? Or do you have the idea that if you do laparoscopic colorectal surgery, could be that you have to convert, and then you have a midline incision? Or what kind of incision do you do? So just, is there any thought about this in your SOPs, for instance?
I wish I could perform a laparoscopic colorectal resection putting all my trocars in the midline, but this is impossible.
Yes,
So, and I wish I could predict that my patients would get such kind of recurrence that they would need most probably you. But this is again impossible, I'm afraid. Of course, when we're operating on people, we're not thinking that we're not going to get any recurrence at all. This is impossible. Okay? But
can I give a short comment on that? If you put in your camera and you see that the patient has cardiomatosis, that's what you should do to start with. Assess the abdomen when you put in your camera. If there is cardiomatosis, put out the camera, send the patient to hyperexcitable.
I totally agree with you on that.
Exactly as we said yesterday, if you come in, you find cardiomatosis in open surgery, don't do a resection, send the patient to the center. It's exactly the same with laparoscopies. You should never end up in this situation that the doctor
definitely for this, but this is a different thing, and I totally agree with you, definitely.
Okay, on that high note, we'll end that session. Thank you very much.